And we are going to now kick it off with a talk about genetics, everything that you and your family need to know. I'd like to welcome Jill Stopfer, also a frequent flyer with us here at the BPREP Patient Forum to update us on genetics. So thank you, Jill.
Excellent, excellent. So let's dive right in. I'm Jill Stopfer. I'm a genetic counselor at Dana-Farber, and I'm going to go through some basics about genetics. What is the intersection between genetics, that which you inherit, and risk for cancer? So I just want to start out to say that in most cases, cancer is not the result of things that you have inherited, altered genes that make you live your life at significantly increased risk. And we have this pie chart of ways that we think about hereditary risk. So when we talk about hereditary risk, we're typically talking about those who have inherited a mutation or problem in a gene that makes you live your life at very significantly increased risk. And this risk is really largely due to this one powerful gene all by itself that's really amping up the chance to develop cancer. And then you may say, well, what is this category familial? How does this differ from hereditary? And we know that many people may have some shared common genes that are running in the family that also raise the chance to develop cancer, but it may not be one powerful gene by itself, but rather a collection of genes that together create what I call your genetic set point. And most health conditions run through families in this way. So, for example, risk for heart disease, risk for high cholesterol, risk for diabetes. It's not all coming down to inheriting a mutation in one gene by itself, but rather your genetic set point. And then there's the sporadic category, meaning that there wasn't a particular shared set of genes or hereditary single powerful gene, but still cancer can develop due to all the things that were discussed before. And so, what are clues about the presence of hereditary cancer gene or risk due to one powerful gene mutation running in the family? So, overall, is there more cancer in the family than you would expect to see just due to chance alone? We know cancer is common, but if we look at this particular family tree, we see two cases of breast cancer at early ages. We see ovarian cancer. There's more cancer here than you would predict just due to chance alone. We see it in multiple generations, not just in isolation in one person. We see sometimes rare types of cancer in the family, indicating a higher chance for hereditary risk. Seeing a single person who's got multiple cancer themselves can be a clue about the presence of hereditary risk. And then what the specific cancers are, and are these cancers that can run together due to a mutation in a specific gene? So, as a genetic counselor, what are the sorts of things that we do to try to help in this space? Genetic counselors go through detailed information about your personal and family history, and we often are the ones to discuss the benefits and limitations of genetic testing and what might this add for you? How might this help? We go through the options for testing and help you select the one that is most appropriate for you. And importantly, we also help interpret results, which are not always straightforward. For those who do have hereditary risk identified, we can help adjust to that new information for both you and your family and work together with you as a member of your team over time to ensure that you receive the appropriate follow-up care. Another important thing that genetic counselors do is when we do identify genetic risk is help other family members get engaged in their own genetic testing. So how does genetic testing work? Often it's done on a blood sample, a saliva sample. Usually those are the two most common ways. And I like to think about genetic testing being kind of like a spell checking process. A gene is spelled with chemical letters, and the letters have to be in the right order. And they can't have letters missing. Just like if you look at a word that's severely misspelled, you might not know what you're looking at. It doesn't mean anything. It's the same thing with a gene. So here I have two examples where I've just used alphabet letters instead of the chemical letters that make up a genetic code, just to demonstrate this point. So the left, you can see it says theater, and that that is spelled correctly, that gene will work. And when a gene works, it's a message to produce a proper protein. On the right, you see there's a scrambling of the letters, THXQ. That doesn't mean anything. And so this is an altered gene. We would consider this a mutation. It scrambles the message sufficiently so that you're not going to get proper protein. We all have these genes, but if you have a version of a gene where the blueprint message is not being received, you're missing that protein, and that's what leads you to live your life at increased risk because having this protein is something that protects you from developing cancer. And so, specifically, how does this help? Why would anyone want to know that they have an increased risk or possibly hereditary risk for developing cancer? Well, in summary, there are things to do about it. It's not just knowledge to provide knowledge unto itself, but it's knowledge that leads to things like getting advice about specialized personalized screening that may be quite different from what the average person is going to be doing, the average risk person. Having the specialized screening can lead to better chances to detect cancer at its earliest stages where there's a better chance for good outcomes. In many cases, there are opportunities to lower cancer risk or even prevent cancer risk from manifesting. And if we identify that there is hereditary cancer risk in the family, there may be multiple members of the family who can benefit from this knowledge. So, what might this look like? Well, screening may include things such as breast MRI imaging in addition to mammography. This is not what the average risk woman is getting. Breast MRI imaging can always be ordered when indicated, but it may not be a routine unless we know that someone is at increased risk. And also, if someone has genetic risk, sometimes we start at a significantly earlier age than would otherwise be offered. We know that cancer susceptibility can sometimes lead to increased risk for more than one type of cancer. So, for example, there may be higher risk for colon cancer. And if that's the case, we can start colonoscopy at an earlier age, and sometimes we recommend that be done more frequently. And then sometimes there may be an included cancer risk for which screening wouldn't be done at all for average risk folks in the general population, such as screening for pancreatic cancer that might help. If someone is diagnosed with a breast cancer and they know they have genetic risk, it can help people make the best decision for themselves about managing risk for second breast cancer. So, as an example, some women may want to consider having bilateral mastectomy instead of just a mastectomy on one side, if that's their choice, or bilateral mastectomy versus lumpectomy, because there's a higher chance to develop another breast cancer if you are genetically predisposed due to a high risk gene. It doesn't mean that someone needs to do that. It just gives you more information so you can make your own best decision about what you want to do along with your physicians. Sometimes there are surgical options like removing ovaries, fallopian tubes that can dramatically lower cancer risk and can be life-saving interventions. But this is not something where, as you reach a certain age, women automatically have this. This is a very specialized kind of decision that would typically be made only if you knew about risks being significantly elevated. And then lastly, we know that if one has certain types of hereditary risk, it can affect your doctor's thoughts about what is the best treatment. There are targeted therapy options based on a better understanding of the biology of the cancer that may really be helpful. So here's just an example of a number of different high-risk breast cancer susceptibility genes that if there's a mutation in any of these, you can see that there's more than one cancer type associated with each gene. And so we think about each of these cancer types and what is the plan to both lower cancer risk, do special monitoring, and we think all of these things will result in better outcomes. So these are high-risk cancer genes. Here's an example of a family that has hereditary risk due to a gene mutation in BRCA1. Circles on this family tree are women and squares are men. We can see there's 3 generations reflected here. It turns out that the young woman, the circle at the bottom, has breast cancer at 35. It was through her that we learned about the presence of a BRCA1 mutation. She has 3 sisters. One sister had it, 2 others didn't have it. And so the follow-up care that these relatives received was completely different based on whether they did or did not have the gene mutation. There are a number of different genetic testing options that genetic counselors speak with people about. Sometimes there is already genetic risk known in the family, and a single gene test is ordered focusing just on that. There are options to do, we call it organ-focused genetic testing, looking at only breast cancer genes or only colon cancer genes. And we do have kind of an opinion about that, and I'll show you in a moment why that is. We have core multi-gene panels where we're looking at a whole number of genes all at once. And then we have very large panel testing for more rare conditions or people who are just very curious who want to kind of wade into the weeds on possibilities that are increasingly rare. So here's an example of a family that I saw where the person here who came for genetic counseling and testing was herself diagnosed with breast cancer at age 62. And there's some other cancer in her family. There's a stomach cancer in her father. There was a brain tumor in her mother. And so this family before wasn't really highly suggestive of anything. She had genetic testing using a multi-gene panel that was not limited to only breast cancer genes. And lo and behold, we discovered that she had a mutation in a gene called MSH2. This is a gene that is associated with a condition called Lynch syndrome. And Lynch syndrome, here you can see the most predominant risk is for colorectal cancer. And there's a whole long list of other cancer risks that we need to pay attention to. And so I would say this family tree really wasn't suggestive of it. And yet we found this very important piece of information, both for her as well as for her children. This is a condition where we start colonoscopy screening in the 20s, and her children would all have specific screening for this if they were also found to have this mutation. So choice of panel and how many genes to put on the panel, again, is something that we talk about in a genetic counseling session. There are a large number of cancer susceptibility genes, and they're not all the same. They don't all come with the same magnitude of risk, and then the cancer risks will vary, sometimes tremendously. There are major categories that we think about. So we think about high-risk genes, like the ones that I showed before, like your BRCA1 and BRCA2 genes. And then there are these category of genes that we call moderate risk genes, where the chances are still increased, but not as much. And here are examples of some of these genes where you can see risk varies, and whether or not it includes risk for ovarian cancer also will vary. So as an example, here's this gene ATM. This is a moderate penetrance risk, about 20 to 24%. Ovarian cancer risk for the average woman is about 1 to 2%. So I call this a whiff of increased risk. These genes, if there is a mutation in a moderate risk gene, generally, we don't recommend risk reducing mastectomy as an intervention. And when the ovarian cancer risk is not significantly increased, we also don't recommend risk reducing oophorectomy. So knowing which specific gene it is, and also knowing sometimes how the gene is altered will help us make the most specific and appropriate recommendations for you. So as an example here, there's a gene called CHEK2 that is a moderate penetrance gene, a moderate risk gene. And depending on the way the gene is altered, depending on the type of gene mutation, the risks may be different, and it may also lead to different recommendations. And here are some other breast cancer susceptibility genes. And I would also say that for women who were tested in the past and their testing only included BRCA1 and 2, you can see here there's a lot more to check than we had, back, let's say 10 years ago. And the amount of risk we're also learning keeps moving as more and more people go through this genetic testing. So even a few years ago, if you were found to have a mutation in a RAD51C or a RAD51D gene, we were really focused on ovarian cancer risk, and it wasn't clear that there was an increased risk for breast cancer. But more recently, we've learned that that is the case. And so staying in touch with the genetics team for those who have learn they have a gene mutation is also very important. So you can make sure you're getting the most up-to-date information. And so lastly, I'd like to talk about some concerns that people have about identifying hereditary risk and what will this mean to them in terms of access to health insurance. Will it affect their ability to get it? Will they be canceled if they are found to have hereditary risk? It's a very common concern. And I like to divide these risks into a few different categories. First of all, for access to health insurance, most people who get health insurance have it through some sort of group. You have it through your place of work or your partner's place of work. And when you are insured as a group, you are not individually underwritten. It doesn't matter what your personal health situation is, you just access the group. So that's one very important thing to consider. Most people have no risk from having genetic testing information on their record in regard to access to health insurance. Another important piece of protection is something called HIPAA, the Health Insurance Portability and Accountability Act of 1996. HIPAA specifically protects most people from having their genetic information affect their access to health insurance, and it also protects for employment discrimination. And we talk about this individually with folks who are considering genetic testing to see, is their situation any different, or are there any additional considerations? In terms of access to life, disability, long-term care insurance, again, there are different ways one can access these insurance plans. Sometimes it's through a group, sometimes it's through your employer. If you're not individually underwritten, it doesn't matter. But for many of these plans, including life insurance, the more insurance you want, the more likely it is that you will be underwritten. Your specific risks will be assessed, and then they'll offer you a policy, and the cost may vary depending on your individual risk. Some people have already had their life insurance or these other products set in place that it's not a risk as you go through genetic testing. They can't undo what they've offered you as long as you continue to pay premiums. But we do know it can, in theory, affect an insurer's offer to you in terms of the cost of the policy. So some people choose to get their insurance set up prior to genetic testing. And sometimes it's something that they don't know if they'll ever even want these products. So we really spend some time also talking about the risks versus benefits of that. It's not to say that if you get genetic testing and you have a positive finding that you will not ever be able to get these things. That is not true. But we just don't know, and we don't have an ironclad guarantee that it won't come up at all. Other people have concerns about the cost of genetic testing, and it is the case that for most people who are good candidates, meaning they meet insurance guidelines for who should be offered genetic testing, or there are national guidelines that suggest if you have these particular features yourself or particular features in your family history, that you're a good candidate for genetic testing, that it will be covered by your insurance. Um, it's sometimes surprising to people to learn that even if it doesn't, the entire self-pay price for genetic testing is about $250. And so there's always that option. For those for whom $250 is still a stretch, the labs have some generous income guidelines, and many people qualify for reduced cost testing. So we have found that for most people who would like to avail themselves of genetic testing, that it is accessible. And I want to end with some common misconceptions that are present about genetics and cancer risk. One is that some people are told that if you're thinking about your risk for breast cancer or female cancer, that only the side of your family on your mom's side counts. And that's not true. You inherit half your genes from your father, half from your mother, and your father can pass along a gene mutation that will increase your risk even if it doesn't manifest in him. Um, there is a misconception that we see in folks coming to clinic sometimes if they have a mutation in a cancer susceptibility gene that it must also go along with ovarian cancer risk. And that's not the case either. Some do, some don't. And so a tailored conversation is in order. We know that I spoke about the fact that risk varies from one gene to another. So having a mutation in a cancer susceptibility does not mean everyone who has it is a good candidate for risk-reducing mastectomy or risk-reducing oophorectomy, taking the ovaries out. This has to be handled on an individual basis. It has to, of course, take into account personal preference, but we do know that everyone's situation is not the same. There is a genetic testing finding called a variant of uncertain significance, where if we think back to the genetic testing is like spell checking, and sometimes we're not sure what a finding means. There's a lot of normal difference in the way our genes are spelled, and sometimes the lab is just not sure. Most of the time, these findings are nothing. And because the risk is typically so low, we do not follow folks who have VUS results in the same way that we would if they had a mutation. And so that's another conversation that we have in great detail to explain genetic testing findings. And then lastly, some people who've had cancer have had testing of their tumor and think, well, is there any more testing I need because I've already had genetic testing? To which I'll say, not all mutations seen in tumor testing can be seen on the type of genetic testing we do on a blood sample or a saliva sample. We are focused on the genes that you've inherited, not just the gene mutations that are in the tumor. So I would like to stop there, and I think we might have a moment or two for some questions.